Good evening, and thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants. Tonight, the title of our webinar is Raising the Bar, Exploring Higher Level Endpoints from a Head-to-Head Study in the Treatment of Moderate to Severe Atopic Dermatitis. As moderator this evening, we have Dr. Ali Shabazz, Clinical Assistant Professor, Texas A&M School of Medicine, Dermatologist, Westlake Dermatology, and Westlake Dermatology and Cosmetic Surgery. As speaker this evening, we have Dr. Mona Shahriari, Assistant Clinical Professor of Dermatology, Yale University, Central Connecticut Dermatology, Hartford, Connecticut. We would like to thank our supporter this evening, AbbVie, for making this educational event possible. A couple of logistic tips before we begin. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question pane on the right-hand side of your screen. At the end of the webinar, a survey will pop up in your browser and will be emailed to you within 1 to 2 days. We would greatly appreciate it if you would fill out this short survey. And also within 1 to 2 days of the webinar, you will receive a certificate of attendance. It will be emailed to you. Now, without further ado, I would like to pass the floor virtually to Dr. Shabazz.
Thank you, Ashley. Thank you for the wonderful introduction. My name is Ali Shabazz. I am a dermatologist and clinical assistant professor here in Austin, Texas at the Texas A&M School of Medicine, and it's a pleasure to be here out moderating this wonderful webinar series. And I'd like to thank Dr. Leon Kircik, who is the president and founder of the International Dermatology Education Foundation, for inviting me to moderate. As a reminder, IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatological care all over the world through education, especially in underserviced rural areas. As you can see, we've been fortunate enough to have some world-renowned esteemed experts in dermatology talk about various topics in our previous educational sessions, and I look forward to welcoming our next guest today, who is an expert in all things dermatology. If you'd like to follow us and keep up to date, please follow us on Twitter, Instagram, and LinkedIn, as well as Facebook at IDEF_derm. As well as if you would like to, please visit www.idefeducationalseries.com to register for upcoming educational events. And without further ado, I'd like to introduce Dr. Mona Shahriari to discuss exploring higher level endpoints from a head-to-head study in the treatment of moderate to severe atopic dermatitis. Take it away, Dr. Shahriari.
Thank you so much, Dr. Shabazz. It's great to see you. And I'm very excited to be talking to you guys about this particular trial and just really raising the bar in terms of what we can expect in terms of our AD treatments in the year 2024. Because I go back to 10 years ago when I didn't have any targeted therapies for atopic dermatitis. I was forced to give a 2-year-old methotrexate because that's the only thing that would control the signs of their AD. So it's really fortunate nowadays where we have a toolbox of medications that we can pick from. And sometimes you don't know which drug to go to. How do these drugs compare? And hopefully our discussion tonight will help set some of those concerns at ease and give you an idea of how 2 of our agents stack up against each other. So let's dive right in. Hopefully I'm moving forward. There we go. And then just some housekeeping points. This program is brought to you by AbbVie. I've been selected by AbbVie to give their talk on their behalf, and I am being compensated for this presentation. So we will stay within the FDA guidelines of everything that we discuss, and this is a non-CME presentation. All right, so what are we going to go over in the next 45 minutes or so that we have with each other? We're going to learn about the impact of itch and rash on sleep and quality of life for our patients. We're going to go through data on a Janus kinase inhibitor, Rinvoq in this case, and how it can help patients with refractory moderate to severe AD. And then we are going to explore the results of a head-to-head study examining a JAK inhibitor and a biologic, so Rinvoq and Dupixent. Now, when we evaluate our patients with AD, many times we're solely focused on the rash that we can see. But the reality is that the skin doesn't tell the whole story. And itch is one of those unseen burdens that significantly impact our patients. And arguably, it's the most significant issue that our atopics struggle with. But unfortunately, itch isn't included in any of our measures of disease severity. And until recently, it wasn't even a primary outcome in our clinical trials. So here you can see the evolution of the endpoints for AD clinical trials from 2014 to today. And what you see is that a 4-point or greater reduction in itch was the bar for itch relief in our early clinical trials. And despite itch being such a big player in the lives of AD patients, it was a secondary endpoint. However, over the last 1 to 2 years, we've been challenging the norm and raising the bar for what our AD patients can expect from therapy, not only with respect to skin clearance, but also with respect to itch. So now we're not only going to look at higher levels of skin clearance like EZ90, but more stringent benchmarks for itch, like an NRS01, which is complete shutdown of itch. And for the first time, we're including itch as a primary endpoint in our AD clinical trials, which really shows the evolution that's happened over the last decade. And we're taking the conversation one step further to not just look at EZ90 or NRS01, but a joint endpoint of skin clearance and itch relief to ensure you're adequately controlling all the dimensions of a patient's experience with their atopic dermatitis. Now, there are other PROs beyond itch that can give us information about the patient experience with disease. The FDA doesn't give much weight to PROs. They prefer nice objective metrics like EASI scores and IGA scores. However, sometimes you can't see that multidimensional burden of disease that a patient's struggling with. And in those instances, PROs become very relevant and give us an idea of the patient's overall experience with their chronic disease. And two scientifically validated PROs are SLEEP and DLQI. And what you see here is that a severe state score, what numbers fall into that category, but what that really means to the patient is the AD is significantly impacting their quality of life and their sleep. But you also see what an ideal state score is. And that means the AD is having no impact on that patient's sleep and quality of life. So to really better understand how sleep and quality of life impact our patients, we did a post hoc analysis of all the patients in the RINVOQ clinical trials, Measure Up 1, 2, ADDUP, who were on treatment and placebo. And at baseline, what you can see is that these patients had moderate to severe impact on their sleep as well as their quality of life. And actually, I'm going to build out this slide and then we're going to talk about the content on it so you guys can really take it all in. So I'm going to break this down for you. So the first question that we really sought to answer for our patients with AD is EASI-75 achievement enough for our patients? To answer this, we looked at the proportion of patients that achieved ideal state scores, which means no impact of the atopic dermatitis on their sleep or quality of life after 16 weeks on RINVOQ, stratified by the EASI response. And this is the dark blue and the lighter blue that I'm going to focus on. And what you see is of the patients in this post hoc analysis that achieved ideal state scores, the vast majority of them had achieved EASI 90-100. And comparatively, you see what a fewer proportion of those achieving ideal state scores were at EASI-75-89, which was our previous gold standard. So though the difference between an EASI-75 and an EASI-90 may not seem like a big numerical difference to us, you can see it means a lot to the patient from a quality of life standpoint. But then we took this a step further and asked, are high levels of skin clearance like EASI-90-100 enough? So now I'm going to focus on that teal color. And to answer this, we took patients who were high achievers in terms of their skin. They had gotten to that EASI 90-100 benchmark. And again, we looked at the proportion that achieved ideal state scores, but this time we stratified it by itch. And what you see is that the vast majority of patients who had achieved NRS01 and EASI 90-100 were able to get to ideal state scores in terms of sleep, quality of life. Not depicted here is that the proportion who achieved EASI 90-100 and an NRS of even 2, it's a much lower proportion. So what this really told us is it's not enough to clear the skin. That skin clearance needs to be accompanied by high levels of itch improvement in NRS01 to profoundly impact our patients and allow for them to lead healthy, normal lives. Now, this slide here is just to help you think about how do you assess the impact of a patient's itch and rash. Hopefully everything I've gone over emphasizes the importance of not only examining your patients that you see in clinical practice, but taking that examination and visit a step further and asking them about their itch, asking them about quality of life burden, asking them about sleep, the psychosocial impact of disease, so you can really understand where they're at so you can appropriately treat the whole patient. So with all that background information, let's turn our attention to RINVOQ, which is raising the bar in terms of allowing our patients to achieve those endpoints, EASI-90, shutdown of itch, and see how it fits into our atopic dermatitis toolbox. So let's start out with who is the RINVOQ patient who's going to be the candidate for this drug. And I'm going to break down the indication. So it's FDA approved for the treatment of both adult and pediatric patients ages 12 and above with refractory moderate to severe AD whose disease is not adequately controlled with other systemics, including biologics, or when the use of these therapies is not advisable. And you don't want to combine it with other JAK inhibitors, biologic immunomodulators, or other immune suppressive agents. Now, I said that their AD is not adequately controlled. This is really on us as the clinician to ask about. If their skin is clear, but they're waking up in the middle of the night itching and scratching, that's not adequate control. If they're clear on the day of the visit, but they get frequent AD flares, that's not adequate control. So again, we need to dig deeper with patients to truly assess adequate control. Also, the indication says that patients have to have tried and failed the systemic. That systemic can be prednisone, methotrexate, or a biologic. You do not have to fail a biologic to go on RINVOQ. That's a really important thing to keep in mind. And how is RINVOQ dosed? So the 30 milligram dose, which we're going to look at in the trials, was a dose that patients started on, is not the approved starting dose for this drug. For any patient who's 12 and above or less than 65, your starting dose is going to be 15 milligrams. And if an adequate response is achieved, you can bump them up. If an adequate response is not achieved, you can bump them up to the 30 milligram dose. Anyone over the age of 65, you can start them at the 15, but they're going to stay at the 15. You're not going to be escalating their dose from a safety standpoint. All right, so now I gave you guys some hypothetical scenarios of what it means to have inadequately controlled AD, but let's talk about a real patient and her experience with uncontrolled AD to really put it into context. Meet Nikki. She's a 35-year-old female with AD who's tried and failed oral steroids and topicals with inadequate relief of the signs and symptoms of her disease. She's never been on a biologic and is currently on a birth control pill. She has had AD since age 5, and when you talk to her, she tells you that she wears gloves for just about anything besides getting in the shower because her skin always feels irritated, burns, it hurts. She even scratches when she's sleeping. I'm sure this story resonates with many of you because we've seen this patient every day in our clinical practice. When you look at her exam, she has severe disease. The IgA is 4, EASI is 27, and her itch is a whopping 8 on a scale of 0 to 10. So keeping Nikki in mind, what are some reasons to consider RINVOQ for her? And this is kind of what we're going to go through throughout this entire conversation. We're going to review how with RINVOQ, she can achieve a rapid response with meaningful improvement in her itch as early as 2 days and a 75% improvement in the clinical signs of AD in as little as 2 weeks after starting RINVOQ. And those results are durable out to 3 years. We're also going to review how with RINVOQ, we're raising the bar of what she can achieve in terms of skin and itch relief. We're talking simultaneous achievement of EASI-90 and complete shutdown of itch. Endpoints we've never had the privilege of talking about in the atopic space before until now. And spoiler alert, when we raise the bar for efficacy, RINVOQ comes out superior to Dupixent in a head-to-head trial, and we're going to go through that as well. Finally, we're going to go through the 5 years of safety data so Nikki can be comfortable with what she can expect while on RINVOQ. And she'll also be happy to know that in the real world, 1 in 4 patients that go on RINVOQ have never been on a biologic, just like her. Now, when deciding on a treatment for our AD patients, there are many considerations like what I just discussed, but also the AAD has offered guidelines to help guide our treatment decisions in our everyday clinical practice. And per the AAD guidelines, Rinvoq has received a strong recommendation in favor of its use for adults with moderate to severe AD. This is the exact same recommendation that's been given to biologics. Interestingly, the AAD has conditionally recommended against the use of systemic steroids, to give you some perspective on how they analyze things. And I agree with this. I do not like to use steroids in my clinical practice if I can avoid it, because in our AD patients, it may seem like a quick fix, but from a side effect standpoint, rebound standpoint, it is not an ideal agent. All right, so let's start by reviewing the pivotal trials that gave us the safety and efficacy data for Rinvoq, Measure Up 1 and 2, so we can talk to Nikki about the efficacy that she can expect. So a high-level overview of the trial design. Patients were randomized to either receive placebo, Rinvoq 15, or Rinvoq 30. This was a monotherapy trial, and as I mentioned before, the 30 milligrams is not an approved starting dose for Rinvoq since the FDA label came out, so just keep that in mind. And what you see is 2/3 of patients are getting to EASI-75, and 4 out of 10 are getting to clear, almost clear, with about half getting to a meaningful reduction in itch with the 15 milligram dose after 16 weeks. But how fast did we see results? We saw EASI-75 as early as 2 weeks, and a meaningful reduction in itch as early as 2 days after starting in Rinvoq. Now, we saw this in the clinical trials, but I've seen this degree of itch relief in real life. I had a patient once tell me, "Doc, I don't know if it's in my head, but my itch was better that afternoon." And this is really the first time in my career that patients have called me because they were happy about a treatment I gave them instead of calling to complain about something that went wrong. And if you prescribed enough, you'll be able to see those results as well. But as I mentioned with Rinvoq, we're raising the bar and looking at more stringent endpoints like EASI-90, EASI-100. And what we see is about half the patients get to EASI-90 and nearly 1 in 5 get to EASI-100 after 16 weeks on the 15 milligram dose of Rinvoq. But we can look at data for hours. Photos are where you can really see the impact that this drug is making. And what you see on the left is a patient with 70% BSA, an EASI of 43, IG of 4 at baseline. I think we all agree it's a severe patient. And after just 16 weeks on Rinvoq, you see that 80 melt away. That EASI drops to a 1.6, and the IJ is almost clear. Though those numbers aren't zero, I think we can all agree that this is a happy patient. Now, AD is not a 16-week disease, but a lifelong disease. So the ability of a drug to offer long-term disease control is important to our patients. What you see on the bottom of this slide is the efficacy achieved with respect to EASI-90 at week 16 is consistent and durable out to the 3-year mark, with 2/3 of patients getting to EASI-90 after 3 years on Rinvoq. But another way to up the ante is to look at a more stringent benchmark for itch. In the top graph, we're looking at the proportion of patients achieving NRS 0.1, which is considered an itch-free state. And with Rinvoq, we have about 40% of patients on the 15 milligram dose getting to this itch-free state at week 16. And this is consistent and durable out to the 1 year and the 3-year mark. Now you might say, I've seen this 40% number before. What's so special about Rinvoq? Remember, other drugs are showing you a 4-point or greater reduction itch, what we saw before. This is complete shutdown of itch. Those are 2 different endpoints, so you don't want to get confused. So now let's take the conversation to the next level and talk about Level Up, which is the head-to-head study against Dupixent, the latest bit of data that we can talk about. And while Dupi has been in our trusted companion for years, this study will show you that while both Dupi and Rinvoq are effective at treating AD, Rinvoq brings a fresh perspective and may have the edge that your patients are looking for to really achieve that complete control of the signs and symptoms of their AD. We're going to start with the study design. So it is a head-to-head, and it was an open label but assessor blinded study, which meant the person doing the assessment had no idea if the patient was on Rinvoq or Dupixent, and patients were started on the drug per the label recommendation. So ages 12 and above. For Dupixent, we did have to look at the weight-based dosing. And at week 16, we were looking at the proportion of patients that achieved simultaneous EZ90 and NRS01, which is a novel endpoint and certainly a high bar to achieve. This was a monotherapy trial, and per Rinvoq's label, if an adequate response was not achieved with the 15 milligram dose starting at week 4, they were eligible to be dose escalated to the 30 milligrams. So again, we're really trying to mimic what we're doing in the real world to truly compare these two drugs in clinical practice. And you see there's 2 periods to the study. I'm going to focus on the first phase, which is through week 16, but stay tuned for period 2, which looks at the Dupi EZ75 non-responders that switched to Rinvoq 15, which is again very practical for day-to-day clinical practice. Now you might say, don't we already have a head-to-head with Dupixent called Heads Up? Why did AbbVie do the Level Up study? So as I discussed at the early of this presentation, it's not enough to get patients to EZ90 to 100, but that skin clearance needs to be accompanied by high levels of itch relief to profoundly impact our patients. In essence, a higher level of disease control requires both high level skin and high level itch control. So keeping our patients in mind, AbbVie was looking to challenge the standard of care and design Level Up with the patient experience in mind. And Level Up was really the first study to combine both stringent skin and itch endpoints in an effort to elevate what control could mean for our patients. There we go. So what did we find? Drum roll, please. I'm going to start with EZ90 and NRS01 achievement separately, and then we'll look at the novel endpoint. At week 16, you see Rinvoq is superior to Dupixent in the proportion of patients getting to EZ90, as well as the proportion getting to that itch-free state. In fact, you have twice as many patients getting to an itch-free state with Rinvoq versus Dupixent, which you see on the right there. But I know the joint endpoint is what everyone's very interested to hear about. And what we see is 2 times as many patients on Rinvoq achieve this joint endpoint in comparison to Dupi at 16 weeks. And this is statistically significant. But what it shows us is that in an era where our AD patients are striving for the most complete and highest level disease control, you have a much higher probability of success if you give them Rinvoq in comparison to Dupixent. But what I just showed you was a snapshot of the week 16 results. How fast did our patients see results? And this is going to be important for everyday clinical practice. We actually had a statistically significant number of patients in the Rinvoq arm achieve that shutdown of their itch, NRS01, as early as week 2, with nearly 1 in 5 getting there at the 4-week mark. And this was superior to Dupixent. And remember, these are all patients on the 15 milligram dose, because dose escalation was not allowed until we hit week 4. Moreover, we have a quarter of patients getting to EZ90 at week 4 with Rinvoq, and that too was statistically superior to Dupixent. So not only do our patients have a higher chance of getting to EZ90 and NRS01 with Rinvoq versus Dupixent at week 16, they also get to these stringent benchmarks quickly. And the sooner we clear the skin and shut down the itch, the sooner our patients can begin to heal and live their best life. All right, so I covered a ton of information, but what you've seen thus far is that with Rinvoq, we're strongly controlling the signs and symptoms of atopic dermatitis, and we're doing so better and faster than Dupixent over a 16-week period. So the final piece of the puzzle is going to be safety. Now, even though Rinvoq is new to us in dermatology, it's not new to medicine. We have 11 years of trial experience across 13,000 patients, 5 years of real-world experience with over 250,000 patients treated worldwide with this drug, and an approval down to 2 years of age in PSA and polyarticular JIA. So lots of data to help us understand the overall safety of this drug. So I'm going to start by just walking you through Rinvoq's clinical trial journey. The first clinical trials began in 2012, and Rinvoq received its first indication for rheumatoid arthritis in 2019. But trials with Rinvoq continued, such that today it's approved for psoriatic arthritis, atopic dermatitis, UC, AS, non-radiographic axSpA, Crohn's disease, and polyarticular JIA. But let's take a closer look at what happened in December of 2021. This is when the FDA issued a class-wide box warning update based on data from another JAK inhibitor in high cardiovascular risk patients. This was when the results of the oral surveillance study came out, basically. And the oral surveillance study was a post-marketing safety study that compared the safety of tofa to a TNF inhibitor in high cardiovascular risk patients. These patients had rheumatoid arthritis, were at least 50 years of age, had at least one cardiovascular risk factor. And in this study, there was an increased risk of death, malignancy, MACE, and VTE in the groups receiving the JAK inhibitor and the group receiving the TNF inhibitor. So as a result of this study, and this study alone, the FDA issued a class-wide box warning update across all JAK inhibitors used to treat inflammatory conditions, including our itty-bitty topical, so that we could consider these risks because they felt maybe all JAK inhibitors possess similar risks. And the FDA wanted us to be cautious and not expose patients to undue risk and keep these potential risks in mind. And these additional warnings were added to not only Rinvoq's label, but like I said, all the JAK inhibitors that are used to treat inflammatory skin disease. But when you really look at the data specific to Rinvoq, there's an increased risk of non-melanoma skin cancer and serious infections, including TB and zoster, with higher rates with a 30 milligram dose versus the 15 milligram dose. We'll go through the other elements of these additional warnings in the upcoming slides, so I can put it into context for you for our atopic dermatitis population. Now, before we go through the safety of our trials, who were the patients that we studied in our 80 clinical trials for Rinvoq? There's this misconception that we studied only healthy Olympic athletes in our Rinvoq trials, and that couldn't be farther from the truth. Rinvoq was studied in patients ages 12 to 75 with a variety of comorbidities. At least 50% of them had one cardiovascular risk factor. 30% were current or former smokers. 20% of the women were on an OCP, with 10% of them being over the age of 40. And why am I telling you all this? What I want you to know is that we studied Rinvoq in patients that look just like the patients you're seeing in your real-world clinical practice. And hopefully knowing this will put the safety data that I'm going to review into context and give you comfort in using Rinvoq in patients that look like this, who have a variety of comorbidities. So I'm going to start by going through the safety of Rinvoq in the placebo-controlled 16-week period, so in the short term. When I look at a busy table like this, the first thing my eyes are drawn to is the rate of serious infection. Those are infections that landed someone in a hospital or required IV antibiotics, and you see the rates are low and comparable to placebo. I'm hoping that you guys can see that arrow there. And then for the rates of malignancy, MACE, VTE, GI perforations, those things that we're concerned about in patients that are on a JAK inhibitor, I see lots of zeros and low rates overall. But I will draw your attention to the herpes zoster line right there. And that is something that we do see with Rinvoq as well as other JAK inhibitors. So I usually suggest patients get the shingles vaccine because it is indicated in anyone over the age of 18 who's on a medication that makes them more likely to get a zoster breakout. But we know some adverse events take time to develop. So here you're looking at the adverse events of special interest out to the 5-year mark on the right and the 16-week period on the left for comparison. And the safety of Rinvoq in the 5-year period is consistent with what we saw in the initial 16 weeks. No new safety signals, no escalation of the previous safety signals. Rates of malignancy, MACE, VTE are low and in line with the general population. And though a definitive Rinvoq safety outcomes trial hasn't been done, based on this data, there's no signal for an increased risk of mortality, malignancy, MACE, or VTE. Now, this is a bold statement that AbbVie is making here, but they have the data to back it up, as you just saw. But remember, the known risks associated with Rinvoq include non-melanoma skin cancer, serious infections, including TB and zoster, with higher rates with the higher dose of the medication. And you might be wondering, what about the pediatric population, our 12 to 17 crowd? The safety of Rinvoq in the peds population is consistent with what we saw in the adults. No new safety signals there. In fact, there's lots and lots of zeros, which makes me feel more comfortable with overall safety. Now, what about the safety of Rinvoq in the Level Up trial, period 1? The safety was consistent with what we've seen with Rinvoq in the other trials, no new safety signals here. But instead of having you guys sit at home losing sleep over these box warnings, and is my patient going to develop one of these, and am I going to get a call about that? What I want you to be more concerned about are the most common adverse events that patients can get on Rinvoq, which they will call you about if you write enough prescriptions, because it's just a numbers game. And when I see a busy table like this, I focus on the top 4 or 5 when I'm talking to my patients. And URIs, acne, herpes simplex, headache, blood CPK increases, those are the ones I'm really going to talk to patients about. Familiarize yourself with this list, because like I said, if you write enough scripts, patients will call you with one of these, and you want to be comfortable talking them through it or managing it. All right, so after all that safety information, let's go back to Nikki. After discussing the risks and benefits of Rinvoq, we start her on the 15 milligram dose per the FDA label. Her itch improves in a few days. Her eczema is melting away in front of her eyes, and her clothing choices are no longer dictated by her atopic dermatitis. Her itch is down to a 1 from an 8, IgA is a 1 from a 4, and most importantly, she says she's happy. She says her itch is getting better, and she's not as troubled by it throughout the day. And before I talk to you about other practical points with Rinvoq, just remember that this isn't just a patient whose atopic dermatitis we're improving with Rinvoq. This is a person whose life we're changing with Rinvoq. And that's what goes through my head every time I see an atopic dermatitis patient in my practice. What can I do to change their life? Now let's get started with Rinvoq. If you have a patient like Nikki in your practice and decide on Rinvoq, what are you going to do? What are those cardinal practical points that you have to kind of walk through? So first, pick the right patient. Make sure they're an adult or adolescent ages 12 and above whose disease has not been adequately controlled with a systemic. Again, that systemic can be prednisone, a biologic, does not have to be a biologic. Make sure she's up to date with her immunizations, isn't pregnant or trying to get pregnant. Check TB, hepatitis studies if appropriate, CBC, CMP, lipids at baseline, and then I periodically recheck at 3 months and every 6 months thereafter, and I'm happy to take questions on that. And you want to remember to start with the 15 milligram dose in all those patients under the age of 65, and you can go to the 30 milligrams if an adequate response is not achieved, again, only in the patients under the age of 65. And finally, you're going to enroll the patient in Rinvoq Complete to give them that streamlined access experience. There's a lot of ways you can get the drug, but my experience with AbbVie's Complete program across their portfolio has been very positive. So I would suggest considering using that to just make the process easy for not only your office, but also for the patient so they can get on drug and stay on drug. And then when it comes to documentation, some best practices to remember, because a lot of times what our note says is going to dictate whether or not the patient gets the drug. Ask patients about the impact of their disease. I always include beyond just BSA and IgA scores. I put an itch score. I put in a quality of life impact, any psychosocial impacts, because this will move the needle with certain payers. Document responses in their health records. So are they getting better? Are they not? Was there anything that they tried and failed? Maybe the treatment is too cumbersome for them. Maybe they tried it and they're having an adverse event, or they're just not getting to that adequate control that they're looking for. And ensure that you put a lot of specifics in the notes. So if they've tried and failed a topical steroid, I try to list which topical. If they are inadequately controlled, I try to say, okay, it's the itch level, that's not where it needs to be. Just, again, as much detail as possible to make your note bulletproof for the insurance company. All right, we're getting close to the end. Just some important safety information to remember. I touched upon this earlier, but Rinvoq does come with boxed warnings. Serious infection is the main one that was on the label before the FDA issued that class-wide box warning update, which basically says that patients on Rinvoq are at risk of serious infection, and it's more common if they're on concomitant immune suppressants like methotrexate or steroids. So just respect the label. Use it as a monotherapy and avoid combining it with other immune suppressive agents. Now, when it comes to the other box warnings, these were gifted to Rinvoq from the oral surveillance study. And we want to keep them in mind, but just be aware of what the nuances are with respect to the oral surveillance study. So when it comes to mortality, in that study, we saw higher incidence of mortality in the group receiving the JAK inhibitor than the group that was receiving the TNF inhibitor. When it comes to malignancies, we saw a higher incidence of malignancies, again, in that oral surveillance study in the group receiving the JAK inhibitor than the group receiving the TNF inhibitor. But lymphomas and other malignancies have been seen in patients on Rinvoq. So if a patient is a smoker, they may be at a higher risk. So if someone does develop a malignancy, you want to discontinue Rinvoq and treat accordingly. Non-melanoma skin cancers can happen in someone on Rinvoq. We're dermatologists, we screen our patients for skin cancer. I would just keep doing what you normally do. With respect to cardiovascular events, in that post-marketing safety analysis and oral surveillance, we did see a higher incidence of cardiovascular events in the group that was receiving the JAK inhibitor than the group that was receiving the TNF inhibitor. So you want to screen your patients at baseline for their cardiovascular risk. Usually what I do before I walk into an exam room, whether I'm seeing someone who has acne or they have atopic dermatitis, I'm looking at their medication list. I'm looking at their past medical history. I want to know this person's health before I even walk in the room. And then when it comes to blood clots, again, in that post-marketing safety analysis, higher incidence of blood clots in the group that was receiving the JAK inhibitor and the group that was receiving the TNF inhibitor. So at baseline, you want to screen your patients for an increased risk of clotting. Sorry, there's a little bit of a delay. Hypersensitivity reactions can occur with Rinvoq. It is contraindicated in anyone with a known hypersensitivity to upadacitinib or any of its excipients. So in those scenarios, you want to stop the drug, treat accordingly, and then reconsider the safety moving forward. GI perforations have been seen on some patients on Rinvoq, usually when they're taking concomitant NSAID type medications, and it is more common in individuals who have diverticulitis, for example. But if a patient calls you with non-specific abdominal complaints, take it seriously so that you can make sure you're not missing an abdominal, a GI perf. We talked about the lab monitoring for this drug. The main reason is there are some lab abnormalities that you want to be aware of. CBC abnormalities, they can drop. Lipid abnormalities, they can go up. Liver enzyme elevations like drug-induced liver injury, again, they can go up. So you periodically monitor them and then consider discontinuing the drug if you're seeing any abnormalities. Anyone who is pregnant or breastfeeding is not going to be a candidate for Rinvoq. We don't study these patients in our clinical trials, so I usually check with my patients what their plans are to get pregnant if they're of childbearing age, and then we decide together what makes the most sense from a therapy standpoint. Vaccinations, you want to get patients up to date with their age-appropriate immunizations prior to starting Rinvoq, and then avoid the use of live vaccines, and Rinvoq's not recommended in patients with severe hepatic impairment. All right, so this is our take-home slide. What do I want you to remember? We went through a ton of information. With Rinvoq, patients can achieve a rapid response with meaningful improvement in itch as early as 2 days and 75% improvement in the clinical signs of AD as little as 2 weeks after starting Rinvoq, with those results being durable out to the 3-year mark. And with Rinvoq, we're raising the bar in terms of what our patients can expect from their AD treatment in the year 2024. In a head-to-head with Dupixent, 1 in 5 patients achieved simultaneous EASI-90 and complete shutdown of their itch, which is what patients need to be able to live a normal life free from the constant impact of their AD. And Rinvoq was superior to Dupixent in that trial. And Rinvoq has become the #1 prescribed JAK for AD with over 8,000 unique prescribers, 1 in 4 patients that are bio-naive, they're being prescribed Rinvoq for their AD after a systemic failure. And finally, when you look at the updated AD guidelines, it's been given the strongest level of recommendation in favor of its usage to treat moderate to severe atopic dermatitis, which is on par with what we see with our biologics. So really, Rinvoq is elevating that standard of care and what we can offer our patients. So you really want to become familiar with it so that you can offer it to appropriate patients in your everyday clinical practice. And with that, I thank you for your attention and I will take any questions.
Thank you, Dr. Shahriari. As always, a pleasure. So one of the questions I'm looking at right now is, how do you talk about safety with your patients? That's a great question.
That's a great question. I feel like I get this question all the time because the box warnings can be scary. And I find you have to be confident in what you know about the data and be able to transfer that to the patient. Otherwise, if they sense the slightest bit of doubt in your voice, they're not going to want to go on the drug. But usually my conversation with my patient is, there's this new medication, it's called Rinvoq, and it's like pouring water over fire in terms of how quickly it can calm down the signs and symptoms of your eczema. We have checked some blood work before we start you on it just to make sure there's no reason why you can't be on this medication, but it's generally well tolerated, with some people getting an extra cold or acne. Now, when you get the box in the mail, you're going to see some scary words. It's going to say things like heart problems, cancers, blood clots. I want you to know that those warnings are not specific to Rinvoq. They have to do with another medicine that's used to treat a different condition, but because the biology of the two are similar, the FDA wants to be cautious and put these warnings on Rinvoq's label. After looking at your medical history, I don't think this is a significant concern for you, but anytime I give my patient any medicine, I want you to call me if something doesn't feel right, because you never know when it could be some rare side effect of the medication. And now it's your turn to ask me questions. And I open the floor, let the patient ask the questions. And I'd say I have a pretty good batting average. 9 out of 10 patients that I want to put on the drug will go on the drug.
Absolutely. That's a great analogy, and I love the way that you break it down, because I think it's more about how you deliver it and which way. It's all about confidence, and we know the JAK inhibitors are a great tool that we have in our armamentarium. Another great question, thank you for that, is where does Rinvoq fit in your treatment algorithm? And that's a great question that has been asked right now.
Yeah, and I think as I started this talk, I mentioned that it's nice to actually have an algorithm, because we really had nothing 10 years ago, and we had to struggle with some of our non-traditional systemics that really aren't targeted for the AD pathways. But there are places where I use Rinvoq as a first-line agent in my toolbox. Anyone who needs rapid disease improvement, they need this atopic dermatitis gone yesterday. Maybe they're having a big major life event, they're going off to college, or they're having a wedding coming up. I also like it for intermittent seasonal therapy. So patients who maybe are doing well all year round with their topicals, but every winter they end up getting a flare, so you give them a short intermittent course of the drug. Also, patients that are concerned about the ocular side effects of biologics. If someone has a strong history of conjunctivitis, I'm a little concerned to give them biologic medication. So I think Rinvoq would be a more appropriate first line. And then if I can treat 2 diseases with 1 drug, I love to do that, because again, less medication is always better. So if I have other autoimmune diseases I'm treating, like RA, psoriasis, PSA, UC, HS, you name it, I would preferentially give Rinvoq over, say, a biologic that doesn't necessarily treat those. And interestingly, atopic dermatitis on the hands and feet, I've had really good luck with this drug when those areas are preferentially involved. So there's a lot of ways to play around with it in everyday clinical practice. I think that's the art of medicine. We get to figure it out based on each person's individual wants and customize a treatment for them.
Absolutely, and I think those are great points. Less is more sometimes, and with medicine as well. That brings me to my second last question. Actually, the last question is, what patients do you use Rinvoq for, first line versus second line? You kind of alluded to it right now.
Yeah, so the first line was I kind of went through. Second line patients would be those who may have had either an inadequate response to a biologic, or they had an adverse reaction to a biologic. I had patients on biologics, for example, who had conjunctivitis, arthralgias, that I've switched over to Rinvoq with resolution of their symptoms, but also that inadequate control. And that's the question you really have to be asking patients about, because if you walk in the room and you ask the patient, are you doing well? They say, yeah, I'm doing better. If that's the end of the conversation, you're not going to pick up on the person that needs even more control. So I take it a step further and I ask them, are you happy? Are you still waking up in the middle of the night, itching, just to get a better idea? And sometimes it's easy to ask those questions. Other times you might want an objective tool. I love the atopic dermatitis control tool. It's 5 or 6 easy questions. It takes 30 seconds because I've taken it myself. So it's really easy for patients to do, and I can tell you right there if this is someone who needs more advanced therapy or their current biologic is working for them.
I love that. Thank you so much, Dr. Shahriari. As always, the pleasure having you on here. With that, we conclude our webinar series today. And thank you again to our lovely sponsors, AbbVie, for sponsoring this event. Just a friendly reminder, if you have any questions, you're welcome to always leave it in the chat box before, and we will answer them after. And then just as a reminder, for our next session on Thursday, November 14th, we will have Dr. Ashish Bhatia discussing the treatment innovation, discovering ZORYVE, the 0.15 for a new indication. Thank you everyone for attending and have a wonderful evening. Bye-bye.
Yeah.